Please take your seats as the program is about to begin. Please take your seats as the program is about to begin.
The World Health Organization estimates that 2.2 billion people globally either have poor vision or are blind. And many of these visual impairments result from preventable and treatable conditions. And in many low-income countries, access to quality eye care is challenging because the services and the facilities don't yet exist to care for everyone in the way that anyone would deserve. So to provide vision-saving care to underserved populations, GlowCare is announcing a Clinton Global Initiative commitment to action to bring its mobile eye clinic, which is the size of a briefcase, to remote regions of the globe that historically have had limited access to traditional vision and eye care. Medical assistants will be trained to provide comprehensive eye exams using their cutting-edge technology. And for more complex eye health care needs like cataracts or macular degeneration, patients will be connected to an ophthalmologist to collaborate on appropriate treatment. Far too many people around the world suffer from preventable vision loss. And with GlowCare's innovative mobile eye clinic, more people in more places will have access to consistent quality care so that they can live the fuller, healthier lives that they and we all deserve.
Please welcome to the stage Patrick Dempsey.
very much. Good morning. Can you hear me okay? Everybody in the back? Well, first of all, it's a tremendous honor to be here, to be speaking at this event for the Clinton Global Initiative and working together, right? It's about bringing people together and collaborating. As you can see, this is a picture of my mother. And the reason I'm here, I'm going to tell you the story, is that my mother was diagnosed with ovarian cancer in 1997. She would have over 12 reoccurrences. It seemed like almost every other year it would come back. So the impact of a cancer diagnosis on your family, I don't know if anyone out here in the audience has had that. I'm sure several of you have. What it does to the family, how it affects everything. And certainly my mother, who was sort of the rock in the family, the strength in the family, was destabilizing. And 17 years of battling this was very challenging, to say the least. But in that, there was a miracle that occurred, which was the founding of the Dempsey Center in 2008. So what we do there, and it really was inspired by my mother and her journey and the things that we had come up across, which was the services that we provide. Here we are in Maine. So I grew up in Maine. The center that we have two physical centers, Dempsey Centers, one in the town I grew up in, and then one in South Portland. But as you can see, over half of the state lives rurally, right? So it's very hard to get the proper care and getting your screenings and all of that. So what we do at the center is we don't treat the disease of cancer. We treat the person holistically without any cost. They pay for nothing. So they don't have to worry about, are they going to have enough money to have these services? And the services that we provide, as you can see, the comfort and well-being, and certainly complementary therapies and the counseling. The counseling is the most important and the most in demand, either in group situations or one-on-one. And also with COVID now, we have what is called Dempsey Connects, which is our ability to reach people remotely using their electronics or their, we've all been on Zooms and things like that. So we're able to reach people that way. The physical locations, we're starting to see more and more people come back in because they trust and they need to have a sense of community. And the one thing that I'm the most proud of is the community supports this. The money that is raised by individuals and the pride that they take and how creative they are at raising money to make it possible for us to provide all of these services at no cost is incredible. And I had a great platform by being on a show where I could reach people around the world. But I think it's also important for us to remember your backyard. Remember where you come from and make an impact there. That was some of the best advice I received as a young actor starting out. Don't forget where you come from. And I think right now we are connected globally, but we're disconnected to our own communities. Oddly enough, this is something that's happened. We have great ability to reach people, but are we reaching our neighbor? Are we able to reach them in a compassionate, loving, empathetic way? These are the values and the principles that we have at the center. We spend a lot of time and money on research and developing drugs. I'm certainly very excited about the potential with AI and what it can do for the positive aspect of treating cancer, but we still need the humanity. God bless you. And that's what we need, right? We need more empathy, more compassion. That's part of the healing process. Growing up in rural Maine, I remember we had a doctor that would come and visit with a doctor's bag. He would come, your mother would call, your dad would call, and he would come over and he'd give you the diagnosis, right? Which was like this thing, check your eye, and you have, penicillin, which I was allergic to, and I kept telling him I was allergic to it. But those kind of values, that's what we're missing right now in medicine. We have great technology. We have great ability to do these things, but where is our connection with humanity and meeting someone where they're at when they come in the door? And I wish you could experience the interactions I have with our clients that come in, because they're so relieved that someone is there and it's so easy for them to navigate. And we simply ask the question, how can we make your life better? What can we do? And then you have to be ready to take that information and do something with it. Sometimes someone's shaking their head out here so you understand what I'm talking about. I asked a woman, what is the biggest anxiety that you have right now? Your husband has brain cancer. There's a lot of things that are going on. What can we support you with? And she goes, we don't have enough firewood. And our sole way of heating our house is with the wood stove. And one of our board members and I got together, and I'm like, we have enough wood together collectively. Let's just bring her 4 or 5 cord, however much she needs for the winter. And that made a huge difference for her. It took the anxiety away almost immediately. So these are the type of things that we do, as long as, you know, we have all of the other complementary medicines that we do, which is the Reiki and the acupuncture, and then the social aspect of the Dempsey dogs, and helping people with their wigs, and all these little things that go a long way. And this is what we need to be doing. Centers like this are so important. There are a lot of little sub-centers that are happening in hospitals, but not the total wraparound care that we're doing. So our mission is really to take care of the people in our great state of Maine, about 10,000 newly diagnosed every year. We want to be able to reach each one of them as soon as they're diagnosed, because you have this anxiety period that you go through between being diagnosed and then what is going to be the proper, you know, attack with your oncologist, and what type of medicine are you going to use. And this is when we need to get in there and we start to talk about nutrition, about mindfulness, about exercise, all of these things that help take the anxiety away. Also, not only the cancer patient, but the caregivers, let's not forget about them. And the people around them need that type of support as well. They're trying to keep it organized, they're trying to keep everybody on schedule, but who is there for them? And also the children. If you have someone in your family who's been impacted, a mother or a father, we have a group there that are taking care of our children in a format that is really moving, because it's easier when you have young people together and their ability to talk about things, or the art that they do to open them up emotionally, to be able to get this emotion flowing. We have a cancer in our society where we're just so at each other all the time. I think what the beautiful thing about growing up in New England and its beginning concept was about sense of community and taking care of each other. So that's what we're doing at the center. If there's more information or more you want to talk about this, I want Cara Valentina, please stand up. She's our CEO and president of the Dempsey Center. Does a great job. We have a great board. We have an incredible staff. And I thank you all for this time, and I look forward to talking with you and finding a path forward where we can work together and improve our own communities, not only locally, but around the world. So thank you for that.
Please welcome to the stage Felicia Nall.
Let me start by thanking you all for being here during lunchtime and saying that we need a Dempsey Center in every city in the world, all over, to close global cancer divides. And that's what we're going to talk about. We're going to talk about how to help people get treatment, but also how to help people get care and reduce their suffering. So as a woman who has lived breast cancer and continues to live all of the survivorship issues post many years of treatment, and having cared for a very dear loved one who passed from their cancer, I'm truly especially grateful to the Clinton Global Initiative for this session, but also for very decidedly choosing to include the patient voice and the caregiver voice in today's panel. And we have an incredible lineup, but we're going to start with our commitment, which is from Seema Scare, the president and CEO of Surgo Health. Please, welcome.
Thank you. All right. Consider these shocking statistics. 42% of US cancer clinical trials do not include a single Black patient. Now, while Black people make up 15% of US cancer patients, they participate in merely 4% of clinical trials. This is no different for our Hispanic communities, who account for about 13% of our cancer patients, but only about 5% of clinical trial participants. So good afternoon. I'm Seema Scare, and I'm the CEO and co-founder of Surgo Health. I stand here today not only as the leader of this company, but as a passionate advocate for a future of healthcare that is more human and more inclusive. And I want to invite you to join us on this mission to redefine the fabric of healthcare itself. And I'm sure we all agree that clinical trials are the bloodline of research and of medical progress. However, what we are also seeing is that there's a real gap in clinical trials. Clinical trials serve as the compass in our roadmap, not only to better understand, but also prevent and treat cancer patients. But we can all agree that a lack of diversity in clinical trials has really bad consequences and ripple effects. So first of all, it leads to a lack of efficacy data on key subsegments of our population. It also means that treatments are not going to be available for all of our community. It also erodes trust in the medical institution, and it perpetuates this belief that healthcare is not for all. Now, through my work in healthcare for about 20 years, one of the things I've realized is that we have to deeply understand why people participate or not in their healthcare to be able to forge a path forward. Similarly, we need to understand for every single potential trial participant, why is it that they may not be able to participate or adhere in a clinical trial? And that is the mantle of change that we have taken up at Surgo Health. We are designing a SaaS platform called Mosaic Trials to elevate and really improve clinical trials to make sure that diversity and equity is at the forefront. Mosaic Trials includes our proprietary AI technology and analyzes millions of novel socio-behavioral data to really understand the barriers that stand in the way for patients to participate and adhere in clinical trials. So we're not doing this alone. We're actually forging on that pathway in collaboration with pharmaceutical companies. In 2024, we are going to be ready to launch a commercial version of Mosaic Trials, which we hope is going to redefine how clinical research is going to be done and innovate. So as our commitment to action, we want to really redefine healthcare. We want to make sure that every person's voice and equity is represented in clinical trials, and we want this to benefit every single person that needs it. Thank you so much.
Well, and now we're going to welcome our panel. Dr. Lutz Hegemann, Dr. Cyprian, and Joette Walters. Please join us on stage, and we will have a seat and share with this group that has given up their lunch to be with us. So I wanted to tell you a beautiful story, a history of closing the global cancer divide at the Clinton Global Initiative. So 13 years ago, it's a while, I had the honor of sitting on a CGI stage with the late Paul Farmer, who many of you may have worked with or know or read some of his work. He was my mentor, he was a dear friend, and I know that wherever you are, you continue to be a friend to those who struggle with disease, because that's just who Paul was. And I sat up on that stage with Paul. I was about a year out of chemotherapy and treatment in Mexico. That was where I had my home. That's where I still have my home. That's where I had that treatment. And on that stage, if you were really generous, you could say I had a pixie cut, but I was pretty close to bald still. And I was learning the hard way how to live with all of the symptoms of survivorship with rapid early induced menopause at 42, which is the standard for a young woman with breast cancer. That session included the patient voice, it included so many other important voices, but it helped launch a global movement to close the global cancer divide. And we were criticized that year, 13 years ago, for sort of daring to take or talk about taking resources away from so-called diseases of the poor, and cancer was supposedly not a disease of the poor. And we challenged that hard. We shared data that unfortunately haven't changed very much, but the data haven't changed. We think about 90% survival for children who are diagnosed with cancer in high-income countries, and we think about 15% for a child in Lesotho or Gambia being able to hope for a cure and surviving their disease. But what did change a lot, and this platform made that happen, I can truly say, what changed a lot is that what was never spoken in global health until that session is now a standard. We don't talk about health systems, we don't talk about strengthening health systems unless we are talking about strengthening cancer systems. We think about cancer systems being vital to health system strengthening as being vital to cancer systems. And that in our global health community has been a dramatic change. Now, I'd like us to spend the rest of our panel time speaking about some of the huge strides that have been made to increase access globally, as well as in the United States, but also the tremendous challenges that befall us and that continue to grow as science takes us to new ways of accessing treatments that before we could never think about, and how we can work together to close that global cancer divide. Now, I think I'd like to start with Dr. Cyprian, and I think I'm just going to use first names, if you'll allow me to do that. And I've known a little bit about Butaro because 13 years ago, that was just starting out with Paul and with others. But you've spent a decade working on oncology and access to cancer there, working with others like Dana Farmer, I know, but really on the ground. And our thanks to all of you to all of us, to all of you, because we live that disease. So what are the key elements of a successful program in a country that is as resource constrained as we know Rwanda is, a successful program on offering treatment to people with cancer?
Thank you very much, moderator, for giving me this opportunity. It's really a great honor for me to be here today to share my experience working at the Cancer Center in Butaro. So our Cancer Center was launched 10 years ago with the support from partners in health. And now every year we care for about 2,000 people every year with different types of diseases. And I'm here to share a few lessons we have learned and a few strategies that I think have led to our successes. The strategy number one was integration. So integration is very key to sustainability. We were able to provide accurate diagnosis and safe treatments because of our investment in integration and capacity building across the health system. Patient access to cancer treatment relies on coordination, capacity building, and referrals across multiple parts of the health system, from community health intervention all the way up to tertiary level care, chemotherapy, surgery, functioning labs, pharmacy, trained surgeons, community healthcare workers, all work together to support cancer patients, and health system investment in space, staff, systems, supplies, and social support are very key. Another strategy is a holistic approach to patient care. Our strategy has been really to pay attention to total cost of care and not only focusing on the cost to the health system, but also looking beyond to also care for other aspects of the care. So if you focus only on the cost to the health system, then you will miss crucial information about patient access, attention into care. You need really to have a system in place and people on our team to be able to assess and address the barriers that your patient are facing to access care. Otherwise, the majority of the patient will just drop off because they have to balance between coming to the hospital also and caring for other things in the family. The third one, just to list a few, was engaging and coordinating influential partners. So I can attribute all the successes that we have to great partnership. I would say that we have been very lucky to have partners, great partners who believe in our work and have been supporting our work in the different ways. We have been working very closely with the government of Rwanda to make sure that all our efforts are aligned with the national priorities, and also other partners like the Dana-Farber Cancer Institute have been working with us since we started on the building capacity around diagnosis, education, just to list a few. Thank you.
Thank you so much. And we're going to get back to partnerships. But Joette, I think we talk about a global cancer divide and we think about across countries. I talked about Canada versus Lesotho. But some of the most heinous metrics I have ever seen about inequity come from within this country that spends 19% of its GDP on health. And there's some complacency there that I think perpetuates these inequities and an unacceptable divide. But I also know that your work in the Tuba City Regional Healthcare Corporation on the tribal lands of the Navajo Nation are making a tremendous difference. And would you share with us a little bit about the challenges, but also the successes? What is working?
Hi. Yeah, it's Joette Walters Yinshia. Nash Ejkabahan Nishla, Hanagani Bashashin, last year Dashachana, it's another. Thank you for the question. Thank you for inviting me here today to talk about what we're doing with cancer care on Navajo. I work on Tuba City Regional Healthcare Corporation, a 73-bed hospital that operates on the western part of the Navajo Nation. Our facility, Tuba City Regional, part of that western region that we care for is 6,000 square miles, so it's a very wide rural area. In 2017, we recognized right away we needed a cancer center. There's, for many reasons, desperately needed to address the issues with cancer on our reservation. And in doing so, we started that work. I'd be remiss if I did not mention the name of my former CEO, Ms. Lynette Bonar, and the board of directors at that time who helped establish and got this work going. In May of 2019, we were able to open the first cancer center on Navajo in the lower 48 states. We understand we're the first tribal center to do that. Several reasons exist on our reservation that makes this need so desperate. 524 abandoned uranium mines exist in the area that we live. These uranium mines were abandoned by the federal government when they were stockpiling for the war in 1950 and 1960. So these abandoned uranium mines remain open, which increases the environmental risk factors and then hence the consequence of the high risks of the high incidence of cancers on the reservation. We also deal with a tremendous gap in our social determinants of health. 20 to 40% of our homes don't have piped water, plumbing, indoor plumbing. Electricity as well. Folks do not have electricity in their homes, a good majority of those. Many of our people, 40% or so, live under the level of poverty. 90% of our roads are unpaved. So access to care there's a serious gap. And when our board decided to bring cancer care to Navajo, it was needed. We were addressing a problem that existed that was not getting addressed anywhere else. The other big piece, the challenge with opening the center was financially. Tuba City Regional is a tribal care organization that operates with a compact with the United States in Indian Health Services. And the Indian Health Services only provides funding and support for primary care. It has not contemplated care for specialized care such as cancer. And so that has also limited our ability on how we could fund the center. And so once we've opened it, we essentially have brought care closer to home. Our members don't have to travel 150 miles round trip to get care. The care is at home. It's also at home because we have culturally competent providers who are able to provide that care. Speaking the language, able to understand the people, all of that's available at our center, and that's been probably the best thing that our community has been able to, we've been able to provide to the community. Thank you.
Joette, thank you so much for all you do and for sharing in the language that we needed to listen to, the opening to your remarks. Lutz, I realize that you have an incredibly important position in thinking through the challenges of global health and also sustainability at one of the most important companies working on access to medicines and treatment in the world, Novartis. And we know that medicines are essential, treatments are essential, but it's not the only thing that's essential to be able to have a strong cancer system and a strong health system. And maybe you could share a little bit about Novartis's vision on that.
Yeah, no, first of all, thanks for having me, and great pleasure to share a few of our thoughts that are developed by Novartis, but of course representative to some extent for the private sector as a whole. And I think it's important that we acknowledge the power of innovation, as we have always done. And I think it's fair to say that the life expectancy of cancer patients that has significantly increased the curability of some cancers or better quality of life has been accomplished thanks to scientific and technical innovation. And we've always been doing this and will continue doing it, but then at the same time, we need to ensure that this innovation reaches as many eligible patients as possible. And that is a thought that has increased in its importance over the years. To give you a few examples, historically it has taken up to 10 years for an innovative medicine to be registered, say, in the United States and then reaching developing countries. And we and others have demonstrated that it's possible to bring this time gap down to 0 days. For one of our innovative medicines, we reached regulatory approval the same day in the Republic of Ghana as we did in Switzerland. So this can be done, and I encourage everyone in the private sector to try to reduce this gap. Second, which is very often at the core of the public debate, is pricing and affordability. And of course that is critically important, and we and others are introducing tiered pricing systems, support systems for patients to make sure that the financial hurdle goes away. But then at the same time, we have to realize that even if you donate a medicine and you make it for free, and we have had those experiences, it doesn't mean that it ultimately delivers the benefit medically that's supposed to deliver. And that brings me to what is the most critical part, but also most difficult part, and one where the private sector can play a role, but which we can never do alone. That's the notion of health system strengthening. Truly looking at, Cyprian had said, at the continuum of care that a patient needs, because there's no point in bringing a third-line therapy into a clinic if the first and the second line therapy doesn't exist, or if the patients are not being appropriately diagnosed. So we need to look at those barriers and analyze them, and then find, together with partners, solutions in order to overcome those barriers one at a time to strengthen the continuum of care.
So hugely important that we're talking about integration, the continuum of care, and equity. We have a Lancet Commission on Cancer and Health Systems that is focusing precisely on that and the importance of thinking right across that spectrum. Joette, I want to turn back to you, and I want, if you wouldn't mind, to share with us a little bit of your experience around what I think are some of the most horrific barriers that patients face, which is stigma. The C word is still in many places called the C word. And what have you been doing to destigmatize cancer, to demonstrate that it's possible to survive?
Again, thank you for that question. I think a lot of what we've done is education. A lot of people still don't know that Native Americans exist. They believe it's part of the past. But we're very much alive. We're very much part of this nation's history and a long line of histories. So what we've been doing is a lot of education. One of the things that we did, I had mentioned that we were part of the Indian Health Service, but with local governance. In 2002, our board of directors our community decided that they wanted to take on healthcare themselves. And in doing so, enacted Public Law 93-638, which allowed our community to operate as a tribal entity, compacting with the federal government. So in lieu of the federal government, our organization is caring for over 100,000 beneficiaries, serving the Navajo, San Juan, Southern Paiute, and Hopi communities of Moenkopi. So education has been a big factor. We've also been doing some education work even at the federal level. We were invited, or my former CEO was invited to the Biden moonshot. And it was at that meeting that they did not realize that there was no cancer center in a tribal facility, a tribal reservation anywhere. So with that partnership, and then with those folks that were at that meeting, have established partnerships that continue to today. The cancer support community and others just continue to take that message out there to let people know that we do have a cancer center that needs support, that needs to be sustained, but even more importantly, that more of them are needed across all tribal communities.
So we're speaking about layers of stigmatization. Cancer is one of them, but cancer is a layer of stigma that goes on top of poverty, gender, ethnicity, race, place of origin, and it's so important, the work that you're doing. Lutz, I wanted to go back to you in a very different question, but I think to some extent related, which is about how we can break down barriers. And we do a lot of thinking about telemedicine. The world has changed so much. Thanks to COVID, one of the few good things that came out of what so many suffered and so many losses. And we also have these incredible opportunities with AI, but a huge number of risks. And what do you think we could and should do with the opportunities that we have with these new technologies for communication and sharing of information?
You know, I think it's fair to say that currently digital data and artificial intelligence is being proposed as the panacea for all healthcare problems without necessarily being specific in what it can do. And I think that we are just at the start of a journey here, and we will experience a lot of trial and error. To give you two examples, one is certainly in the diagnostic telemedicine. I look after our operations in Africa, and I think that to a large extent, I see the opportunity for technology to overcome infrastructural immaturity that exists. For instance, you have a shortage of physicians who are specialized in a given field. You can now take a mobile phone, a photo of your dermatological lesion, you can send it to a dermatologist and you get a diagnosis, and the dermatologist never needs to see this patient. The same with radiology or with eye care, for instance. A fundoscopy can be done remotely. So you can expand the reach of what is probably one of the biggest scarcities in the healthcare system, that's healthcare professionals. And I see huge potential here. The other potential that I see is that we can direct our limited resources in a more efficient way. And this is where artificial intelligence comes to play. And through our Novartis Foundation, we are piloting artificial intelligence together with Microsoft to see how can you make sense out of all of these fragmented health data that exist and help guide investments being made in a more precise ways. We are partnering here with the city authorities of New York City to see how can we decipher some of those determinants of health so that the government knows where to invest and that the investment is ultimately having a higher chance of delivering the benefits that it's supposed to do. So two examples where I think, which are very tangible, where I believe that we will see benefit. Of course, there is always risks associated. I think, of course, data privacy and security need to play a pivotal role in everything we do. I think in the health sector and in the governmental sector, this is relatively well contained, other than open source or in the private and open web. But I think we still, of course, need to make sure that we very respectful with all the data that we are entrusted with.
Thank you. And so we heard from our commitment maker about the importance of equitable access to evidence. We're hearing about all different ways of being able to promote equitable access. And Cyprian, there are some very specific and enormous hurdles that the poor and people in Rwanda overall have to get past in order to get access to care. With Joette, we talked about stigma, which we know was one. But in terms of your on-the-ground work, you talked about partnerships, but in addition, what has been key? What have been the elements that have allowed you to go to scale and also to sustain this effort and to bring Butaro to where it is now?
Thank you very much. So the first thing which have helped us to be where we are now, as I said, it was a partnership. We were able to engage different partners to be able to tackle the challenges that we were facing from the beginning. And another thing which helped us is an existing strong health system in Rwanda, where you have all the layers of the health system, from the community healthcare workers to the health center up to the tertiary level. There is interconnection so that it becomes really relatively easy to navigate the patient through the system.
So I think this is a hugely important point and something that Partners in Health has really been a trailblazer over a couple of decades now, is the idea of patient navigation and having often someone who's a patient or has been a patient to help others. But for those of you who may not be as closely aware of this work, it didn't start out with cancer. So it's an incredibly interesting point to focus on patient navigation that started out with other diseases and is now being used so well on cancer. Now, we're going to be able to have some interaction, and I have quite a few minutes with the audience. But just before we turn to that, I have a general question, because I know we're not going to have another chance with the whole group. And you have here change makers. You have people who are committing to doing all sorts of things. Give us a few ideas of what each of them or each of us can do to help make possible what you're suggesting is necessary. Joette, do you want to start?
Thank you again. That's a very good question. I think one of the things is education about American Indians, about Native Americans, and healthcare. I think that's probably the first thing, because we do get a lot of folks that want to help, but they don't understand how healthcare works on Native lands. And so that's probably the first thing. But also, if you're a policymaker, a lot of the things that we're doing and limiting us right now in tribal healthcare is policy. And just recently, in July 31st, after 6 years of conversation and 6 years of going to Centers for Medicare and Medicaid, CMS, we were issued a proposed rule to help carve out specialty meds in the outpatient prospective payment system. It's a proposed rule, and we, with our advocates, have submitted comments and waiting for the final rule, and hopefully in this final rule that we will have the needed reimbursement for specialty meds. But those are the kinds of things that tribal healthcare needs, is help with policy, changing policy, and education for all those who are interested in helping us. Thank you.
So, and this speaks to something in the health systems that we really harp on, which is a diagonal approach. And I think what you're saying is that we can do something about cancer, but we can also do something about population-wide inequities and understanding where we need to invest in education, knowledge. And your point about really struck me, that some people think you're not there anymore. I think we all know now you are definitely there. Usually I think we turn to a company like Novartis and we ask for help, right? We ask for support. We don't usually ask you what we can do for you. We did hear about clinical trials and equity, which is, I think, hugely important, but what can we do? And I think that includes the patient, the caregiver. What can we do to make the challenges that Novartis faces as a global corporation work better to help all of us?
Yeah, I think my first ask would be to appreciate that the pharmaceutical sector wants to be part of a solution and not create a problem. And to be open to partnerships, particularly multi-sectorial partnerships, which in our experience are those that have the biggest reach and the biggest durability. And to understand that there is more that a pharmaceutical company can do rather than just the transaction of selling or giving medicines. That's the first part. I would say, secondly, make sure, and that came out earlier, and I would like to echo it, that we are inclusive in our operations, that we include the perspectives of patients and caregivers, that we move from we make solutions for them to we make solutions with them. And then thirdly, acknowledge that we are all on a journey. I don't think any single organization has all the answers that it requires to address a complex issue. And let's honestly partner and also reassess where are we, where have we succeeded, where do we have to change direction, where can we do more, where can we do less. But that openness to collaborate would be my overarching ask.
That is a hugely important ask because not everyone in global health is willing to sit down at that table. And I think some of us believe very strongly that if we can't have that kind of partnership and conversation, we won't be able to solve some of the kinds of challenges that we see in a country like Rwanda. Cyprian, what would you ask of us to be able to make Butaro global?
Yeah, thank you very much. I was talking to my colleague right before we come here that if we need to tackle cancer control, then we should go beyond. Working in silos like availing one therapy, but look on a more comprehensive way to the whole spectrum of care and really to building the system. Because you can make a lot of effort and avail a second-line therapy, make it accessible to patients, but if they cannot access accurate diagnosis, then the access to treatment will not be worth. If they cannot access supportive treatment or first-line therapy, then it will not work. So we need to have that comprehensive approach and be able to tackle that disease as a whole and not as a single aspect of the care. So I ask the key players here to really think more creatively how they can engage in low-income countries and really decrease the disparities that is there in access to cancer care. Thank you very much.
And I think this really speaks to what CGI is and can do because, I have encountered patients and families where the hugest barrier is actually illiteracy. So we have an education issue because they can't read the slip on which the diagnosis or the medicine and instructions are there for their own child. So can we do something about access to education as well as to cancer care? Now I want to turn to our audience. We have a good 10 minutes or so to be able to have some discussion, questions and answers, comments, and I know we have at least 2 individuals with microphones, so I can't see as well, but I know that our commitment maker has a comment or question right here. Yes, please. Thank you.
Thank you so much, Felicia, and thank you for this amazing panel. Really appreciated the comments. My question was going to be to Dr. Lutz. So you mentioned about the importance of continuum to care to be able to introduce new products into communities, and you also talked about the power of AI at the very end of your comments. I'm curious on the diagnostic side. Do you see some exciting, innovations there, especially to bring to low resource settings that will really help the diagnoses piece, especially as we're grappling with healthcare provider shortage? Thank you.
Yeah, thanks for the question. I would say absolutely. I trained as a dermatologist, and I must say I was really frustrated to read that a melanoma can be more accurately diagnosed by a computer than by a trained dermatologist. But joke aside, I think there is a lot of potential here also in radiography, which of course is particularly important for cancer care. And I think we have just scratched the surface on what is possible and also how that can be deployed in order to overcome these infrastructural weaknesses that we see in many developing countries, but also I would say increasingly so in developed countries where we also see a chronic shortage of healthcare professionals. And I think we need to make sure that we put technology into the service of better, faster, and more accurate diagnosis that has a higher level of equitable reach essentially to underserved communities.
Seema, thank you so much for your question. Do we have... Thank you.
Hi, I'm Leslie King, and I'm a board member of Partners in Health, so this is not an inside question, but I was wondering if Dr. Cyprian could share a little bit about the obstacles for serving cancer for even just the entire country of Rwanda. This cancer center at Butaro is the only government sector in the cancer center in the rural sector, so we can't treat everybody at Butaro. And I think you're just getting your first CAT scan, so we're talking about comprehensive cancer care, but it really has been just a step by step by step. So can you just talk a little bit about the challenges of how many patients you're able to care for, how many more are there out there, what are you able to care for, and what do you have to turn away?
Thank you very much, Leslie. Yeah, as you mentioned, the first challenge is access. Our center has been the first cancer center to be established, and now we have two in the country for a population of 12 million people. So you can imagine that there are other people who really cannot access, because according to the National Cancer Registry, we think that we are missing almost half of the patient that should come to see us. Another challenge is still rate presentation. So we continue to see patients with advanced diseases, and this is making it hard to improve survival for our patients. And then retention in the care is also another challenge, but thanks to the support from partners in health, we are able to really address those issues by providing a facility, a hostel where the patient can stay. We provide transport to patients, but it is still not enough. So there are still efforts that we can do to make cancer treatment more accessible to the patients. Thank you.
And we can't pretend that it is the job of foundations and non-governmental organizations to do what government should be doing. And so I think there's a strong call to insist that countries include cancer care and control in national action plans, but also in national insurance plans. And, you know, I remember when I had the honor of co-chairing with Paul Lancet Commission on Palliative Care, and he said, this is all well and good, but palliative care cannot be an excuse for governments not doing what they have to do to offer treatment and early diagnosis for patients and their families. So a huge amount being done, but an enormous challenge. We have time for one more question or comment. Well, okay, then I will do this mini networking exercise that I threatened to do. Turn to the person to your left, to the person to the right, person behind you, person in front, and introduce yourself, someone you do not know, please, because that's what CGI is all about, and try and promise us that with the goal of closing cancer divides, you will speak to that person or someone else who's here while you get some lunch and some coffee. They are doing it. They're all introducing themselves, you see? If it works in faith-based organizations, it's got to work in CGI. 14 seconds. Okay. So I can tell that you're doing a great job of talking to each other. They really are. And you want to continue talking to each other. I am going to now just thank our panelists. I'm going to thank CGI, the Dempsey family, our commitment maker for this determination to close cancer divides. And His Holiness the Pope said something that I think should drive us in the work on cancer. I can't paraphrase, but what I heard was, there are illnesses that cannot be cured, but no child or person who cannot be cared for. So with that, thank you very much for spending your lunchtime with us and for all you're going to do. Thank you.
Thank you for joining. Please head to your next session. Thank you for attending. Please clear the room as we prepare for the next session.